Hi, we're continuing with the series on borderline personality disorder. This is specifically geared for parents who have adolescent children or even those who are young adults with borderline personality disorder. And as always, a shameless plug for my book, Borderline Personality Disorder, Survival Guide from Chaos to Authenticity. Really, what I'm talking about today, and it's a very broad and complex issue for parents to consider, and that is inpatient or residential care for the child. Um, there are so many benefits of having the child at home. And I say this because sometimes children with borderline personality disorder or other psychiatric issues may have a lot of time outside of the home unsafely engaged in impulsive activity, including sex, alcohol, drugs, dangerous partying, dangerous kinds of adventures for days or even weeks outside of the home. Um, and one of the good things about having the child in the home, of course, is the child can be seen and supervised on a daily basis. You can interact with the child, ask, what's going on? How are you doing? I'm wondering, if we can have a few minutes we could talk. If the child hasn't been to a meal or out of their bed for a few days, you can encourage them by coming out for a family movie, game night, and so on. And these issues are crucial for supervision. Clearly, there are times, though, when the child should not be in the home. And the most important considerations are residential placement and inpatient psychiatric care. Um, what are the advantages to these programs and why should they be considered? First and foremost, they tend to be quite different. Inpatient psychiatric care today is really for acute psychiatric problems. Uh, in the old days, and I'm serious when I say that, in the old days, inpatient psychiatric care was for any acute problem where the individual felt particularly vulnerable and fragile. They felt like they were having what used to be called a nervous breakdown. Their anxiety would become simply unmanageable. They may have psychotic ideation, but also suicidal ideation. Today, the only way to get into an inpatient unit is if you are acutely suicidal. And the reason for that is because without acute suicidality, there will be no financial reimbursement for the inpatient stay. And in fact, if you look at um, admission and discharge summaries from hospital, they'll be very careful to document it in that way. The person's acutely suicidal, and on the last day, of course, miraculously, they're not suicidal. It just happened to coincide with their discharge date. Um, and because of this, you have a lot of people with borderline personality disorder who are not necessarily acutely suicidal, but they are acutely psychiatrically fragile, extremely vulnerable. They're unable to manage. And these are people who are not necessarily going outside of the home doing dangerous, impulsive, crazy things. They may be inside the home for weeks at a time, not getting out of bed, not coming to meals, not wanting to go to school, not wanting to do homework, not wanting to engage with friends or hobbies or activities. And the person feels anhedonia, which is a inability to derive pleasure from daily activities, even those daily activities that the person previously really enjoyed. So what do you do? Um, if the person is not eligible for inpatient care, it becomes very difficult. One issue to seriously consider is increasing therapeutic contacts during the week. In other words, if the adolescent is going for therapy once a week, speak with the adolescent, speak with your child and the therapist, and increase it to 2 or 3 times a week. Additionally, have different kinds of therapy. For example, if you did not have family therapy before, go to family therapy once or even twice a week. This will ensure 3, 4 contact hours or more per week for the borderline adolescent or young adult, ensuring that they're getting a modicum of care that is clearly above the once a week contact that they would normally have. But it also doesn't rise, obviously, to the level of an inpatient psychiatric setting. The inpatient psychiatric setting is really for people, as I said today, who are acutely suicidal. One of the great things about inpatient settings is that they contain potential dangerousness or acute problems. In other words, if you're really doing poorly and you're living at home, you can go outside of the home and get into a lot of trouble if you're not doing well, impulsively and through dangerous activities and so on. And the inpatient unit contains this. It could be a locked unit, although many today are not, but it has a sort of structure, physically, psychologically, and otherwise, that can be extremely helpful for people that are acutely psychiatrically unwell. There's something else which is not usually noted, but really should be, and that is day hospital psychiatry. Day hospital psychiatry has different ways of being conceptualized. Some people conceptualize it as a step-down unit from an inpatient unit. Some people sort of think of it as a, not step down, but a step up from once a week or bi-weekly therapy. Day hospital psychiatry is a program where people attend sometimes several days a week, sometimes 5 days a week, often most or all of the day, 9 to 5, and it'll involve usually a meeting with a primary therapist, 1 or 2 groups, activities that can be therapeutic or just social. It can include enjoying rest time where you may have a half an hour or more just reading and relaxing. Usually 1 or 2 or even 3 meals can be provided by the program. So the person will be going home at the end of the day, but for the majority of days of the week, and sometimes even 5 days of the week, depending on the program, the individual will have a great deal of structure, a great deal of supervision, and when they're doing particularly poorly, it's a great alternative to increasing regular private therapy, and it's a great alternative to also inpatient psychiatric admission, particularly if the person does not qualify because of the bloody healthcare insurance programs that we have. So there are different options for the adolescent child who's not doing well outside of the home that the parent can consider. There are also structured programs specifically for individuals with BPD and similar kind of issues that are inpatient, but it's not inpatient psychiatry. These are programs that see a lot of individuals who not just present with BPD, but present with BPD and other issues. This is very important to understand whether it's for your child or similar children, because so many children with a BPD also have alcohol issues, drug issues, impulsivity regarding sex. They can have social isolation issues, which are very serious and not really regarded with enough consideration by parents at times. They could have developmental issues, and I don't mean specific developmental disorders such as perhaps a reading disorder or a learning disorder, but developmental issues with regard to, where a child should be at different stages of life. Healthy adolescents should be generally quite independent in a healthy way, even from age 14 or 15. By age 16, 17, they should have a defined group of friends, sometimes 1 or 2 best friends, and many of them have a lot of activities outside of the home which are very healthy. And we often see that borderline adolescents don't have that. And as a result, one of the important things to consider is a structured program where these matters can be attended to. These structured programs exist all over, and you can look them up on the internet. I'm not going to recommend one over the other, but they all have benefits. I want to talk about this for a second. One of the advantages of structured and inpatient programs is that you can play around with medication. And by that I mean, usually when someone is living at home and they're recommended one medication or even two medications, it's hard to move them up and down. It's hard to know whether the adolescent is compliant taking the medication. It's hard to know about immediate side effects. There are a lot of issues with regard to it. There's shame, there can be embarrassment. When an individual is in a structured inpatient unit, you can really work with medication in a much more effective and humane way often. And the person will either take the medication, or if they're not taking the medication, sometimes they'll be kicked out of the program. Medication is a crucial part. It's a crucial tool for persons with psychiatric issues. It's not a cure-all. I'm not a psychopharmacologist by any stretch of the imagination. I have my own issues with it, but they can be experimented with, for lack of a better term, in inpatient and structured settings. The other thing about inpatient structured settings is that it will give the family relief time. And I'm not saying this in any kind of negative or even pejorative manner, but the reality is that parents can become very overwhelmed at times with children with BPD, and structured and inpatient units can give the family an opportunity where for several weeks or sometimes more, the child can be in a program where there is a breather. And I don't mean just a breather for the parents or siblings. I mean a breather for the adolescent with BPD, because the person with borderline personality disorder may have been overwhelmed for a very long time with family members due to hypersensitivity issues or transient paranoid thinking, or because they feel they don't physically have enough space, or because they feel that although their family members deep down love them, they just don't understand them or have proper empathy for their issues, because the borderline feels that when they become emotionally dysregulated or throw a temper tantrum, everybody in the family rolls their eyes because they're not taking it seriously, because they think this is just attention-seeking behavior. And so, the adolescent in a structured unit, in a structured environment, is with not just one, but a whole group of professionals, therapists and whoever else, psychiatrists, social workers, psychologists, and so on, nurses, who won't roll their eyes when the individual is overwhelmed, who won't roll their eyes when the person just can't get out of bed in the morning because they feel they just don't have any energy. They will work with the person. And, sometimes the individual will feel, frankly, more understanding and empathy from complete strangers on the structured or inpatient unit than they did from their parents and siblings, even though their parents and siblings may love them deeply, and they may love their parents and siblings deeply. But there's some things that ordinary people that don't have training just don't get. And I see this all the time, OCD, for example. Unless you have real empathy, it's hard to understand just how a person suffers with these whirling obsessional thoughts that won't leave the person's cognition, or how repeated behaviors seem to the outsider to be kind of silly and unimportant and distracting, but to the person who has OCD, the reality is it's extremely debilitating and embarrassing And so the ordinary family member or even friend of the borderline may not get it, but they'll be in a structured unit for, as I said, sometimes weeks at a time or more, where they will have multiple professionals that do get it. Multiple professionals that have seen this over and over and over. And honestly, one of the things about that I've learned over many, many, many years is that to understand a problem in healthcare and specifically in mental health, you have to see it over and over and over. Um, there's so many issues that I didn't understand until I've saw it, literally dozens and dozens or even hundreds of times, um, because so much of what we work with is conceptually based. Um, Many borderlines and persons who have acute problems have severe difficulty with certain basic ADLs, activities of daily living, including managing their sleep schedule and their food schedule, and sometimes moving towards, frankly, very unhealthy eating habits, eating too much, excuse me, eating too little, binge eating, and so on. Eating is a huge issue for borderlines. The reason is, and hopefully we'll have a separate video on this, is that borderlines feel out of control. In general, children feel out of control. There's very little a child can control in childhood, right? Because your genetics are set, your environment is set, and your parents or caretakers are set. So what do you control? Almost nothing, right? You control food intake, what you eat, when you eat, and this is one of the reasons why eating disorders are so important to consider in general for children, but specifically for borderlines. On a structured inpatient unit, sleep is set. There's a lights out time, and there's a specific time in the morning when you get up and you have to go prepare yourself for the day, breakfast groups, and so on. It's very structured. Borderlines do very well with structure. They do very well with certainty and predictability and boundaries, not just ego boundaries and boundaries with regard to self and others, but boundaries in terms of daytime scheduling and so on. Again, the same thing is true for food. Having scheduled eating times with appropriate snacks without junk food or dangerous foods is really very, very healthy. And this kind of structure will allow the borderline, even though they have these parameters, these external parameters for what they're able to do, will actually provide the borderline with much greater internal parameters that the parent will probably not even appreciate because they're not in the program, obviously. But it's something that the parent can't provide at home, even if the parent wants to provide healthy meals and a sleep schedule for the child. Adolescents are adolescents. They're almost young adults, and they have a lot of independent decision making, and they don't listen to parents in general. And these structured programs are great for that. Many borderlines will find that they're psychiatrically isolated. And by that I mean it's unusual for them to find other kids in their class or friends that have very similar symptoms or presentations that they do. And this is one of the reasons that inpatient structured programs and group therapy is really important for borderlines, because they see people with similar problems. And they see how those problems manifest in different individuals in different ways. They see it's not cookie cutter. They see how different people defend themselves against anxiety. They see how different people ensure that they don't become overwhelmed. And they get feedback and input, and they can test out ideas in group therapy or even just, with other people in structured programs during the day or during snack time in a way that is really healthy and structured. In other words, the borderline's not meeting some weirdo on the street who seems to be similarly impulsive and nuts and start up a conversation and think, oh, I can understand myself better through, this stranger. That's not the healthiest way to go. What's healthy is having an individual in a structured therapeutic program with people with similar kinds of issues, discuss with them on a regular basis for, a few weeks or whatever the length of the program is, how they're doing. And one of the things you have in these programs is start to finish, right? You have people coming in and you have people exiting. And it gives the parents and the individual an understanding of, the reality that there are programs that can help, but that you can accomplish something. With therapy, when you go to therapy, you can go to therapy for years and years and years and years, and you don't necessarily accomplish anything. And I'm not saying that in a negative way, because therapy is a wonderful thing. It can be a holding environment. There's a lot that's very good about therapy, but nothing ends necessarily in therapy. It can go on for years and years and years for the adolescent and young adult. In structured programs, it must end, right? And when it ends, you've accomplished something. When it ends, you feel that you have a merit. When it ends, you feel that you're being let out, not just because it's a 3-week program, but you're going home because you're better than when you came in. You've learned something about yourself. You've gained insight. You're more psychologically aware. Your sleep is much better with 3 weeks of consistent rest. Your eating is much better with 3 weeks of consistently healthy eating, right? Your interpersonal interaction is much better. You haven't used drugs or alcohol for 3 weeks, so your body is cleaner. And indeed, there are people who go back for second or even third rounds of inpatient groups and inpatient structured programs. And sometimes the same program, sometimes different kinds of programs. Parents can't do it all on their own. Parents need help from the school. They need help from therapists and other healthcare providers. They need help from pediatricians. They need help from family members. And they must rely on each other in a loving and caring manner. And that all occurs within the context of the home. But at times, the home just isn't enough, and inpatient or other kinds of structured programs where containment is possible can be an extremely useful extension of what should be considered a loving and supportive family. If the person goes to a program, the whole family should go to drop off the person. If the person comes home, please God, the whole family should go to bring the person home. Talk openly about it, joke about it. It shouldn't be taken so seriously. It should be regarded as any other kind of therapeutic adjunct to regular supportive care and love from the parents. Parents who are overwhelmed should know that these kinds of programs exist. Obviously, you need to check with your insurance carriers and the cost and location and so on, but they're a great alternative. And I would say for most adolescents, alternatives that should be considered when they're still adolescents rather than young adults, so they have and can be aware that such programs are available to them as they grow and develop in a safe and healthy manner.